I'm back. So we're going to talk today about our clinical experience with use of mesenchymal stem cells in orthopedics. And this is just going to be focused on autologous adult mesenchymal stem cells in orthopedics. Obviously, things tend to go from more invasive to less invasive to least invasive in medicine. And in cardiology, we've seen that with bypass grafting. When I was in medical school, everyone had the standard CABG scar who was 50 years or older. Now we see that moving on to angioplasty and stents. Same thing in orthopedics. The 1940s, there were many open joint surgeries and then arthroscopy. And going to be talking about what we believe could be that next advance in orthopedics. Just some basic information. We're going to be talking about adult, non-embryonic stem cells and only autologous stem cells, i.e. from the same patient. There are multiple different kinds of adult stem cells out there. We've talked about various ones here today. The group we're going to be speaking about is mesenchymal stem cells, so we'll talk a little bit about those. Basically, lots of research on this stem cell line. If you had to pick one adult stem cell line that's out there right now that has the most prolific research published on it, it's arguably this one. It's been shown to differentiate into lots of different directions and repair various organs. This is actually just the publishing activity, which is kind of interesting on this stem cell line. You can see here that it takes off as around 2001. I checked this morning, there's 9,942 published articles as of this morning on mesenchymal stem cells. So it's really been exponential growth of this type, or I'm sorry, 9682, I messed it up. 9,682 articles that have been published. If you have small kids, I also call these Bob the Builder cells. Simply because they also focus on managing the repair response. So they almost act like a general contractor in that they'll bring in new blood supply, they'll act as construction managers, bring in different cells to help in the repair response. And some of their effects may well be paracrine rather than through differentiation. You know, should we be using allogeneic cells at this point? As we've said through the ICMS guidelines, we don't believe that that's at this point ready for prime time, but I think those will be ready in the future. There are some issues. There's been papers published that show that the genes in the donor cells remain active in the host. That can be a good thing and that can be a bad thing. Obviously, there may be some immune rejection problems in allogeneic cells, particularly as they differentiate. So as they're an undifferentiated stem cell, much fewer immune rejection problems, but as they differentiate, much more. And genetic disease may actually be transmitted. This is a really interesting study where they took mice who were bred to have osteoporosis. They took the mesenchymal stem cells of those older mice, senile mice, who had osteoporosis. They put them into young mice, and the young mice got osteoporosis. So a genetic disease vector, which was kind of an interesting study. So obviously there's some risks with allogeneic cells. As far as delivery is concerned, at least when it comes to hematopoietic stem cells and mesenchymal stem cells, there is a pulmonary first pass effect. So most of these will end up in the lungs if you inject them IV. Now Henry brought up this morning that BLSCs and perhaps V cells may be small enough to not get trapped in the lungs, and that may open up different delivery systems for different stem cell types. But there was one study recently that showed that about 10 in a million mesenchymal or hematopoietic stem cells injected IV ended up in the brain. So extremely tiny numbers of cells that are actually getting through this pulmonary first pass effect when it comes to the bigger stem cell types. So how rare are mesenchymal stem cells? They're fairly rare. There's about 1 in 10,000 and 1 in 500,000 of the marrow-nucleated cells. Obviously, the marrow-nucleated cells are only a small portion of what's in the marrow as well. When we first started in 2005, we were using BMAC, bone marrow aspirate concentrate. It was easy to get. You can have a bedside centrifuge that can make it. You can mix it up in the lab. The big problem for us in orthopedics, even though BMAC has been shown, I think, to work reasonably well in cardiac and in vascular and in other areas, was that it didn't work for us in orthopedics. Again, this is what we were using. It's rich mostly in these blood progenitors, which obviously are very important for cardiac applications and vascular applications, but very poor in mesenchymal stem cells. So for us, it really was a spectacular failure. For a whole year as we treated patients with BMAC, we saw very little effects in the type of orthopedic and pain conditions that we were treating. And there was recently a paper published that shows that maybe why this was the case. If you take 60 mLs of marrow, which is a common marrow draw volume, you only get about 70 to 90,000 mesenchymal stem cells, whereas most of the research in animal models would show, at least in orthopedics, that somewhere in this 10 to the 7th, perhaps even 10 to the 8th range is what the dosing requirement would be. So you're well below the dosing requirement with just a standard bedside centrifuge approach for what we do. Very different if you're, I think, focusing on these CD3/4 cells. So these are rare cells. We needed to start trying to culture expand them to bigger numbers. Again, in the animal research, and there's about 10,000 papers published. This is what's done to get to clinically relevant numbers. But there were some problems in doing that. Normally what's used is fetal calf serum. There were some problems, so we modified an already existing type of culture where you took the patient's platelets, you got out the naturally occurring growth factors, that was used to grow the patient's cells, and these platelets contained the growth factors that you needed to culture expand the cells. So you were limiting exposure of the cells to exotic growth factors that are commonly used in research. These are 350 or so culture expansions, clinical culture expansions here. This is the million or millions of stem cells on this axis. And what you can see here is that if this is sort of the therapeutic band that you're looking for at a minimum, you can see here some patients who really can't expand to that number, some patients who are well above that number knocking the ball out of the park, and most of the patients fall within this band. But it's pretty interesting to see the biologic variability in culture expansion of how well people grow stem cells. Everyone from that person there to that person there, about a 300-fold difference between those two people. If we look at surface antigen expression of the cells that we grow in culture, and this is just a map, radar type map here where you can look at these antigens, CD105, 14, 29, you can see that it's fairly consistent in its surface antigen phenotype. As far as our clinical experience is concerned, we've been doing this now for about 4 years, since 2005. We only use, again, autologous culture expanded bone marrow and synovial fluid-derived MSCs. Again, we use an animal-free, exogenous growth factor-free technique. We deploy these through a needle, so even though these could very well be deployed surgically, our background in interventional pain management has had us focus on percutaneous deployment. And we've got a 4-year active tracking database that now has 300 or 400 patients in 700 or 800 procedures under our belt. If we look at, I think, what's next in orthopedic type care or orthopedic medicine, it's going to be a little different than what we've had to date. What we've had to date has really been a focus on quick fix. And if you're going to actually replace a joint, that's probably a very reasonable path to take. But if you're going to try to save a joint, you probably need to know a lot more about what's going on with that joint rather than just a quick fix. So for us, this means going beyond quick fix solutions and asking yourself, how did the musculoskeletal system get this way? Because if you're going to fix it, you've got to not only put in magic stem cells, but you've actually got to figure out why you need the magic stem cells in the first place.